Hello. Thank you, Dr. Kaniecki, for having me on today. My name is Tanner Purnhagen. I'm a graduate student at Case Western Reserve University at the Dorothy Ebersbach Academic Center for Flight Nursing. I'm doing my MSN as the Acute Care Nurse Practitioner program, as well as the DNP. Today, we're going to talk about pediatric mechanical ventilation. This is just going to be a brief overview of pediatric mechanical ventilation and some pearls to get you out of trouble and some things to remember. Currently, I work for a local flight program. I'm one of their ventilator educators, and my research interests for the DNP focus around mechanical ventilation and critical care transport. I'll have my email here at the end, but it's trp32@case.edu if you have any questions regarding pediatric mechanical ventilation or mechanical ventilation in general, or just the flight program. Please feel free to reach out to me. Again, thank you for having me today. I have no disclosures to make. But if you wish to pay me for your product, let me know. Objectives, we'll get through them real fast, but just review indications for mechanical ventilation in children, some basic setting, modes, and outcome variables, management of common pathology and some pearls, as well as some special circumstances that we see in kids, especially in critical care transport, kids we'd be asked to transfer, and then some quick troubleshooting tips. So really the basic indication for mechanical ventilation is patients with an advanced airway need to be ventilated with a ventilator properly. It's very easy in the early aspects as well as with children to just bag children because it can be difficult to ventilate. However, we really need to put them on the mechanical ventilator with proper settings from the get-go to avoid iatrogenic lung injury. You know, the old saying is, why does a BVM always work? Is because there's no high pressure valve or no high pressure alarm. And you don't know how much tidal volume you're administering. So really, any kid with an advanced airway needs to be on the ventilator. Initial ventilation strategies are going to vary kind of depending on what's going on with the kid, but there's three main indications for airway management. The actual scope of airway management is kind of beyond what we have time for today. However, one thing to remember is really you should be using the most experienced intubator available, because these can be stressful and often chaotic situations when trying to manage the airway of a child. But inadequate oxygenation, inadequate ventilation, or inability to protect the airway. So real quickly, inadequate oxygenation if they're hypoxic despite supplemental oxygen, whether that be nasal cannula or non-rebreather. Inadequate ventilation if they cannot get rid of their CO2, think asthma or some sort of obstructive disease. And inability to protect airway, seizure, coma, altered mental status, neuromuscular weakness, something that would prohibit them from clearing secretions and maintaining the patency of their own airway. So those are the big indications for airway management. Again, that's kind of beyond the scope of what we have time for today. But if they meet these criteria, they should be intubated and placed on the ventilator.
Hey, Tanner, I agree. Can you go back to slide? We're not going to talk about airway management, but one thing that sticks out to me, I'm not a pediatric expert, but I see this photo of a child in the sniffing position when the teaching is always something under their shoulders. They have a big head and you don't want. Is this proper positioning for a little one? I know
so from what I've found, I agree with you. The classic shoulder, because kids have larger heads, is to place something over the shoulder. But you accomplish two things with this: is you get a little bit of ramping, but at the end of the day, as long as that ear's to the sternal notch, and you have something to elevate the shoulders to bring everything in line. I think, however you do that, they just encourage the use of a headrest because they have large heads. And so you may just need an extra shoulder roll if you're using that headrest, but really it's elevating the shoulders to bring the ear to the sternal notch.
Yeah, that's a good point. That works both for adults and peds. But I saw that with the sniffing head ramped, and it went counter to what I've been taught all these years.
And I think that maybe calling it the sniffing position is incorrect because it's not a true sniffing position, but I think what I would take out of that is just the ear to sternal notch, and making sure the shoulders are elevated, because again, the children have much larger heads, and bringing the shoulders up will get the axes more in line.
Yeah. All right, we'll move on. I think you're right. We don't have time. There's so many nuances in intubating that we're going to talk about ventilation.
If we had more time, and that may be a subject for a different day.
Yeah,
But again, these can be chaotic and stressful. And so use your most experienced intubator, use video laryngoscopy, take your time.
100%.
So settings, we'll talk about each of these individually, but set by the clinician or the independent variables of the respiratory rate, the fraction of inspired oxygen, tidal volume, positive end expiratory pressure, PEEP, inspiratory time, and then the dependent variables, kind of the result of the variables you have set, are the minute ventilation, peak inspiratory pressure, plateau pressure, and exhale tidal volume. And so you'll see tidal volume in here twice, but set by the clinician is inhaled tidal volume, and what's resulting on lung pathology, compliance, and resistance is exhaled tidal volume. So the first thing we'll talk about is tidal volume. Following ARDSNet, this was the study, remember, back in 2000 that looked at high tidal volume versus low tidal volume, high plateaus versus low plateaus. And we know that low tidal volume, specifically lower pressures, are better as higher tidal volumes can increase mortality. So following these guidelines, tidal volume is typically set at 4 to 8 mLs per kilo for adults. However, when we talk about children, we really need to account for dead space. And I have a couple pictures next that'll show some more examples of dead space, but we have to remember that dead space is air that does not participate in gas exchange. So either in the circuit, in the endotracheal tube, in the upper airways, it's not participating there at the alveoli. And so it's just kind of dead air that's moving back and forth, but it's not actually accomplishing gas exchange. And it's much higher in the kids than in the adults. We also have to remember that dead space is higher in infants with respiratory distress or those with bronchopulmonary dysplasia. The bronchopulmonary dysplasia is a little bit of a specialty peds transport. However, those with respiratory distress, the faster they're breathing, the more dead space they're going to have. We really need to increase our flows and specifically our volumes to account for that dead space. If you're in a bind, one thing you can do is titrate your volumes to chest rise. Just like the old AHA teaching was, you would bag until you got chest rise. You can increase your volumes until you get chest rise. A rule of thumb is about 10 milliliters per kilogram of weight for your tidal volume for kids, and that accounts for the dead space. Be mindful of your peak inspiratory pressure and your plateaus, and remember the tidal volume exhaled here is important because even if we're putting 150 in, we may only be getting 50 out. And so that 50 is the only thing that's actually exchanging because we lose 100 in the circuit. So these next pictures should hopefully illustrate that a little bit better. So we see here, can you see my mouse?
No, I don't see the mouse.
That's okay. I'm not sure how to make that.
If you're in presenter view, there's a little thing you can select and bring up a red dot.
Okay, so in this picture, we see a couple different things, but it just talks about the dead space. So C, the circuitry, A, the HME, and B, the endotracheal tube. So that's all, air is moving through this whole place, but it's not actually ventilating the lungs. So one thing to remember with the Hamilton T1, the flow sensor here at the end, that's what's actually measuring the tidal volume. So it'll ensure that that tidal volume gets here, but not necessarily to the child's lungs. And so there's a couple different kinds of dead spaces. We have instrumental dead space, as we said, the HME, other connectors. Think about the end tidal CO2, the flow sensor. We have physiologic dead space, just about a milligram or a milliliter per kilo. And then alveolar dead space, physiologic dead space if they have a pneumonia, something that's not participating in gas exchange. And if we look here, we see the endotracheal tubes can be 15 to 25 mLs, the HME 20 to 90. If you think about a smaller child, 90 mLs may be your entire tidal volume, and you can lose that in the HME. So just it's something to be very mindful of. When you have too much dead space, what you're going to see is increased end tidal CO2 and a decreased oxygen saturation because you're not getting rid of that CO2 or the CO2 is building up and you're not pushing oxygen in. So again, if that happens, you have a child on a ventilator, titrate to chest rise, add a little bit more pressure, remember the pathology, the underlying insult, and increase your tidal volume. Sometimes about 10 per kilo is what you need initially.
Yeah, it also highlights the importance of choosing the correct pediatric circuit and not using an adult one, because you just have so much more dead space.
That's a really important point. And in the Hamilton T1, for example, the recommendation from the company is that under 15 kilos should really use the neonatal circuit, even though the adult circuit will go down to 3 kilograms in a bind. And if you, for example, don't have neonatal mode activated, if you have to use that adult circuit, you're going to have a significantly more dead space that you'll have to overcome.
Yeah, and the other point that you highlighted is it's not about the volume you set, it's what's coming back. So if you have a leak in there somewhere, you have to figure out kind of why you're not getting whatever you set to the patient.
Exactly. Yeah. Be very mindful of that exhaled tidal volume. Respiratory rate. To set your respiratory rate, you can either match their intrinsic respiratory rate prior to intubation, or use a surrogate. Your end tidal CO2 can be a surrogate for minute volume. If their end tidal CO2 is rising, you can raise your respiratory rate to blow off some of that CO2. And if it's too low, you can lower your respiratory rate to retain some CO2. But remember, in critical illness, sepsis, or whatever, you may have low end tidal CO2, but you need to maintain that respiratory rate. So one thing you can do is use a reference card or an app. We're not endorsing any specific app, but PDStat is a common one, and I think it's free. Critical, I believe you have to pay for, but it's well worth the money. There's all the information you could ever want on anything there. And then don't forget about the classic Broslow tape. But use a reference card or an app, and that can at least get you started, and then you can titrate to your surrogates of minute volume or end tidal CO2.
Yeah, hey Tanner, I think it's good, whether adults or peds, remind the listeners of, it's okay to raise the respiratory rate of the tidal volume, but you have to understand the parameters you're going to watch after you do that. So the thing that comes to my mind in particular with raising the respiratory rate is you have to make sure they're exhaling, especially once you start getting, I don't know for peds, but with an adult, you start getting up to the 30s, you have to make sure that that volume is coming out. Any comments on that for like the pediatric population?
I think where we're going to see that where it's important, we'll talk about it in a little bit, is asthma. You have to ensure that expiratory time in asthma. And it's a little bit counterintuitive because you're going to see their end tidal rising because they're not getting rid of any of that carbon dioxide. However, the solution to that is to actually lower the respiratory rate to give them that exhale time. I think because the inspiratory time can be a little bit shorter in kids, you have a little more room in the respiratory rate because you also worry about breath stacking. You also worry about dysynchrony when they're breathing so fast. But we'll talk just here in a couple slides about some modes that you can use that can limit that.
Got it.
The fraction of inspired oxygen, FiO2, between 21 and 1.0, usually expressed as a percentage. One thing to do, we know that hyperoxia can worsen outcomes in certain pathology, traumatic brain injury, STEMI, stroke. We do want to wean our oxygen, but I think in the initial stressful times, it's easy to start at 100% and wean down from there. What you don't want to happen is, the vent stuck on 21% if we forget to go up. So start high and wean quickly for SATs greater than 92, depending on the pathology. So inspiratory time, inspiratory to expiratory ratio. The ratio of inspiration to expiration, this is kind of what Dr. Kaniecki you were talking about, can be set by the clinician, but it's typically defaulted on the vent. The Hamilton T1, for example, depending on the weight that you enter, will specify an inspiratory time and therefore an expiratory ratio depending on the respiratory rate. So if you take the respiratory rate, and we'll say is 12, and the inspiratory time is 1 second, based on that rate of 12, a whole breath cycle is 5 seconds. If the inspiratory time is 1 second, you're left with 4 seconds for expiration. So that's how that ratio is calculated. Take your respiratory rate, the amount of cycles in 1 minute, take your inspiratory time, and then whatever time is left is your expiratory time, and then it gives you the I/E ratio. Typically, expiration is longer than inspiration, except for a few certain modes. like APRV, but for the most part, expiration is much longer than inspiration. When you do get more tachypnic and when you do breathe a lot faster, your IDE ratio is limited by respiratory rate and I time. If your respiratory rate is 30 and your I time is 1 second, then it's a 1-to-1 ratio. So remember, in certain pathology like asthma that we talked about, you definitely need that longer expiratory time. So it can be a little bit of a balancing act. And you just have to, again, remember what the underlying insult is. I think something we forget is that the ventilator doesn't really fix anything. The ventilator is more supportive. And so you really need to address the underlying insult. Positive end expiratory pressure, the PEEP. Limited data supports one starting point over another. Use your clinical judgment and remember the disease process. 5 centimeters of water seems reasonable for most. And if you have the ability, if you have the numerics on the vent, you can titrate to PEEP of best compliance and SpO2. So this picture down in the bottom right-hand corner just shows that with a PEEP of 15, which is a little on the higher end, after the first breath, the fifth breath, you really recruit those lungs. You keep those lungs nice and inflated. You keep those alveoli nice and tensed, and you can really permit more and more gas exchange with nice recruited lungs. And you compare the PEEP of 15 after 5 breaths versus no PEEP. There's, I mean, just so much more surface area available for gas exchange. To titrate to PEEP of best compliance on the Hamilton, you have your static compliance number, your C-stat. Start at a level of PEEP, 5 or 8. Increase that PEEP by 2 centimeters, go from 8 to 10. If your static compliance stays the same or goes up, the PEEP is helping. If that static compliance number goes down, the PEEP is not helping. And what that's actually measuring is for that incremental increase in pressure, are you getting an incremental increase in volume? So if you're increasing the pressure, but you get less volume, then you're not helping yourself. You're just, hurting your preload. However, if that number stays the same or goes up, that's telling you that by adding more pressure, I'm getting more volume, thus more surface area for gas exchange, and we want to see these nice inflated lungs right here. So that's how to do PEEP of best compliance. It's always good, especially in the kiddies, to remember the hemodynamic consequences of PEEP. As you increase intrathoracic pressure, you decrease blood flow to the right heart, which decreases blood flow to the left heart, decreasing cardiac output. We shouldn't really sacrifice PEEP for hypotension, but just something to be mindful of, whether you need to give fluid, pressors, blood products. Going up on the PEEP can decrease cardiac output in somebody who's volume depleted. Inspiratory time is typically less than a second in kids and is defaulted on many vents. Like I said, on the Hamilton, if you enter their weight, it'll default a time. It's good to know that shortening your I time has little impact on E time, so decreasing respiratory rate to achieve that longer expiratory time. And my example for that would be, going from an I time of 1 second to 0.8 seconds. 0.2 seconds over 10 breaths is only 2 seconds more of expiratory time, where decreasing your respiratory rate has a much more significant impact on your E time because you're getting a whole extra second per breath, for example. One thing I want to talk about, we'll talk about this next, is P ramp. On the Ravel ventilators, it's called rise time. On the Hamilton, it's called P ramp with small endotracheal tubes. Below here, this is just from Rebel EM. It's respiratory rate, inspiratory time. This is commonly available chart in your PediStat, critical apps, Broselow tapes. It should all be there. But the P ramp or rise time is the period over which the vent increases your pressure. So the inspiratory time is the entire length of the pressures delivered to the breath. However, P ramp or rise time is how fast you get to that top pressure. And I'll show you an example of that next. And I'll show you why this is important to adjust with small endotracheal tubes. So we see right here, this little section from here to right here is the P ramp. So how fast you get up to the PIP. Okay, so this whole thing is the I time, and how fast we get up to that peak inspiratory pressure right here is P ramp. Again, called rise time on the LTV, the Ravel. Why this is important is laminar versus turbulent flow. In a small endotracheal tube, with a very short rise time, you're forcing a lot of air and a lot of pressure in a very short amount of time into a very small tube from a much larger circuit. Versus in an adult, you're going from a larger circuit to a large endotracheal tube. If the P ramp is too fast, and by that I mean it's too short, 20, 30 milliseconds, you get very turbulent flow. This air coming through the circuit is very turbulent, and it hits this endotracheal tube and bounces back. The child will desaturate, they get hypercapnic, and you're not really creating any gas exchange because the vent is pushing that air way, way too fast. However, if you were to slow the P ramp down 100 milliseconds, 120 milliseconds, you get much more laminar flow. It has time to get from the circuit into that smaller endotracheal tube. So in a child, even though they're in respiratory distress, you need to actually slow the P ramp down to get that laminar flow with these little endotracheal tubes. And how will you know to do this? When you put the child on the ventilator, you're going to get high pressure alarms, very low VTE, nothing's coming back because nothing's going in, and they'll begin to desaturate and their end tidal will go up. So if that happens, and you're getting no air back, it's probably because the P ramp is too fast. And so slow that guy down and you'll get much more laminar flow, and you'll actually be able to ventilate the child. Minute volume is respiratory rate times tidal volume, typically 80 to 100 cc's per kg per minute. Use your end tidal as a surrogate. So, and what I mean by that is if your vent doesn't display minute volume, you see it right here, 7.9 liters, you can use your end tidal CO2 as a surrogate. You're also not going to have minute volume if they're pre-intubation. So pre-intubation, if their end tidal's 30, you may not know what their minute volume is, but you can try to match what their minute volume was with an end tidal 30 on the ventilator. And so you can always use your end tidal as a surrogate. And this is just kind of an illustration of what minute volume is, but it's respiratory rate times tidal volume is the calculation. So those are the variables set by the clinician.
Hey, Tanner, do you know, so it's not uncommon for when an adult gets intubated, often they're on BiPAP prior. They don't use the BiPAP mode too often in infants, do they, or children?
I'm not a pediatric expert. I can't really speak to that, but I will tell you the kids that I've seen in significant respiratory stress, I have not seen them on BiPAP. Yeah. I feel like I see a lot more high flow nasal cannula. Yeah. High flow nasal cannula seems to be a lot more tolerable from the little ones. So I don't see a whole lot of BiPAP. If they were on BiPAP, that is an estimation of their minute volume. You would get that on the BiPAP machine, but they also have significantly more leak. Yeah. And so that's one thing to consider. But I feel like I see a lot more high flow nasal cannula.
Two good teaching points here regarding minute volume. If you know what they're doing okay or bad on prior to putting them on your vent, whatever the vent is, you need to match their minute volume. If they're doing good, like your goal is to match that minute volume. And if they're already struggling, let's say they're acidotic or hypercapnic, you need to either match that minute volume or do a little bit better, because if you're not getting the minute volume, you're not going to ventilate your patient. I'll just kind of leave it there. But one trick too is if they're on BiPAP, if you know their minute volume on BiPAP, you can kind of get close to that with your ventilator after the intubation. I don't know if you ever use that or not, but it's a
Agreed.
good
Yeah,
trick.
absolutely. And as long as sometimes the BiPAP will display multiple variables. So as long as you take into account their leak, then using the minute volume on the BiPAP, if it's a non-vented mask, totally acceptable, totally good. Excuse me. And if you don't have that option, you can use end tidal if you've got that. Excuse me. But I would agree and matching the minute volume. And if they're sick, DKA, some sort of sepsis, you need to match that plus some. And the two ways you can do that are by either increasing respiratory rate or increasing tidal volume. Now, tidal volume, we know too high can be associated with lung injury. So sometimes your best bet is just to increase your respiratory rate. Peak inspiratory pressure. So I have this little illustration here, and it looks at some of the pressures that are involved with the ventilator. So the PEEP, the end expiratory pressure, is a pressure which will never get below that number. The PIP, think about that as kind of an upper airway pressure. It's what we're using to overcome the resistance of the endotracheal tube, of their lungs, and depending on their compliance, like to actually get the air in, to increase that flow. That's the peak inspiratory pressure. And so that's this top number. Maximum airway pressure achieved during inspiration. It's the sum of the PEEP plus the inspiratory pressure. So we have the PEEP, which is the baseline. The inspiratory pressure is how much we actually need to get into the lungs. The two of those together create our PIP.
Hey, I have a question for you.
Sure.
Talking about your ramp and rise time with the child. So if I saw this waveform in my head, I think, all right, well, maybe I need to slow down the rise time and I would lower that PIP. Am I thinking of this right?
In a way, I think so. And so this PIP waveform, this is not a true ventilator waveform, but by slowing down the rise time, you give more time for that pressure to build. And in that building of pressure, you're generating flow the whole time. You may achieve your tidal volume at a much lower inspiratory pressure by giving it more time to go in, if that kind of makes sense.
Yeah, it does to me, thinking of this, because here you have a high PIP and quite a difference, between the PIP and the plateau pressure. And the question is, what's causing that? And a small endotracheal tube seems like a potential cause or something prior to the lung,
Sure. Yeah. And even we have to remember that airway resistance, if they need some albuterol, some bronchodilation, something like that can help as well.
Yeah. So this talk probably isn't going to get into ventilator waveforms, but there's a couple of them that can really help you out as a clinician trying to figure out what's going on.
We have just a few waveforms to talk about, more of the modes. But absolutely looking at your waveforms and where I think it can be really important is looking at that flow waveform. If it doesn't return back to baseline, I think I have a picture of a flow waveform. If it doesn't return back to baseline before the next breath, it's indicative of auto PEEP. And that can, really stack against you in an asthma patient or something like that. And that's something you can quickly look at the ventilator and say, oh, they're auto PEEPing. We need to take them off the ventilator and try to press on the chest and get rid of that extra air. So plateau pressure, static pressure during inspiratory pause, you need a zero flow state in the lungs. It's a measure of alveolar pressure and lung compliance. It's difficult to do on the Hamilton T1. You have to use a surrogate calculation of exhale tidal volume divided by the static compliance plus your PEEP. And the reason that is the Hamilton's a pressure-driven ventilator. To get a true plateau pressure, you need a volume control ventilator because you have to deliver a constant volume every single time. To get a true calculation, so you have to use these kind of surrogate calculations on the Hamilton. But it's a measure of alveolar pressure, and this is what the literature has shown to actually be indicative of lung injury. And so in transport, gamut is our database, and the gamut metric is a plateau less than 30. And that came from the ARDSNet study, which was done back in 2000. Again, the high tidal volume versus low tidal volume, but they also compared a plateau of 30 versus a plateau of 50. And in the low tidal volume group, they had a plateau of 30. There was an 8.9% absolute mortality reduction in the low tidal volume group versus the high tidal volume group. And so that's where that info came from, is a lower tidal volume, 6 mLs per kg, plus a plateau less than 30 is now what is considered kind of the cutoff for lung injury or being more closely related to lung injury. And so that's what our regulatory body, Gamut, our accrediting body is looking at is our plateaus pressure less than 30, and that's considered lung protective ventilation. If you have the chance, this is a fantastic study done in the New England Journal back in 2000. It's really the kind of the basis of what we do with our ventilators today.
You know, Tanner, I'll say one of the biggest gaps in knowledge I see, especially coming from nursing, whether you're going to APRN or from nursing to flight nursing, are these concepts of peak inspiratory pressure and peak plateau pressure when a patient's on volume control. And they're absolutely like critical to understand the vent and what's going on with your patient. I don't know if you plan on getting into those here. We can do it another time, but those are two, you have to know them, especially if you're going to be running a ventilator with a patient who's on a volume control. Those are like fundamental pressures you need to know and understand how they're created.
Yeah, I think we'll talk a little bit about it here in how we get to in a volume controlled mode, what is your PIP actually doing. But that's something I completely agree that those are imperative to understand, and the manipulation of such is imperative to understand. Very quickly, this is not a drawing of my own. This was requisitioned off the internet, but the modes of ventilation are important, and what they actually mean is important. So the type of breath, whether it's assist controlled or spontaneous or mandatory, the control variable, volume versus pressure, that's where we're going to focus. And then some timing of the breath, CMV versus SIMV. Nobody's really doing continuous spontaneous ventilation, but we'll get into some of this stuff. So there's insufficient evidence to recommend one mode or the other when comparing outcomes, at least mortality. However, what we're going to do is focus on assist control versus SIMV, and then volume versus pressure, which is kind of the four most common categories you'll see. So it's up to you at the end of the day what you want to use, because there's not good evidence of saying one way or the other. However, there are some times when one is better than the other. We'll talk about that. Just a very initial thoughts. Historically, on kids, pressure control has been used due to either vent or clinician limitations. And when I say that, is some of the older ventilators had trouble, their blowers had trouble generating small tidal volumes reliably. Don't quote me on this, but I think the Revell is under 50. It has kind of a difficult time doing a tidal volume of 50 or lower reliably, where the newer vents, the Hamilton T1, will do a tidal volume down to 2 cc's reliably and accurately. However, evidence has not shown superiority to one mode over the other. If one thing that I was taught early on is you can estimate pressures based on your BVM. So if you have a manometer on the BVM and you're bagging the child before you put them on the vent, you can use that kind of manometer pressure as a starting point for pressure control ventilation. Like I said, though, the newer vents can handle the volume. And so the first one we have is assist control, where programmed breaths are delivered for the set inspiratory time regardless of the trigger. So think about it as full support. However, this can lead to breath stacking. And as Dr. Kaniecki was saying, in volume mode, pressure is dependent. So in a volume mode, flow is constant, but pressure goes up to get the volume. So you, in a volume mode, use the clinician, set a tidal volume of, say, 150. That's 150. The vent will deliver pressure, 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 pressure until it hits that 150. Now, based on compliance, resistance, intrinsic patient effort, that pressure is going to be different every time. We see this one of a PIP of, say, 20. This here was 25, all to get that tidal volume of 150. So why that's important is, in order to generate the volume you want, if you keep needing more and more pressure, you gotta look into something. Do they have a pneumothorax? Do they need more sedation? Are they desynchronous? Are they fighting? Do they need a bronchodilator? Do they need some ketamine? Something like that. But remember that in a volume controlled mode, the pressure is variable, and you got to keep a really close eye on that. Inversely, In a pressure controlled mode, you have a decelerating flow pattern, which can be more comfortable for patients, but you have a controlled pressure. The clinician sets the pressure, the inspiratory pressure above PEEP. The volume you get is varied based on breath to breath. So when you're in a pressure mode, you need to watch the volume exhaled. And again, this can depend on compliance, on resistance, on sedation, on underlying lung pathology, et cetera. If the tube is too deep and you're only ventilating the right lung, you know. So just remember that whatever mode you're in volume, pressure is variable. In pressure, volume is variable. So just two things here in assist control, just to kind of illustrate this. And this is volume control, assist control, so full support in volume. We see here that our pressure, this person has nice, healthy lungs. Our pressure is pretty static, and so is our volume. But what I want to illustrate here is this ramp as it goes up, 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 to get the tidal volume we have set, which happens to be here 500 on this screen. So pressure increases until you hit the set tidal volume. In pressure control mode, the pressure is constant. Here it's 24. The inspiratory pressure would be, what, 18, 24 minus 6. So that pressure is constant above this level of PEEP right here. This person also has nice, healthy lungs because they're getting consistent volumes every time. But what you're doing is delivering pressure for the length of the I time, and then whatever volume you get is dependent on pulmonary mechanics. So two different ways of doing assist control, either pressure or volume. Remember that whatever variable you set, the inverse is kind of what you watch. So if you needed more tidal volume here, you would just go up on your inspiratory pressure. In synchronized intermittent mandatory ventilation, SIMV, it's a combination of mandatory and spontaneous breaths. Spontaneous breaths are pressure supported, allowing for volume freedom. And what I mean by that is that during an AC breath, a spontaneous AC breath, if it's a volume controlled mode and the volume is 500, the patient's going to get 500 regardless of what they wanted. In SIMV, spontaneous breaths are pressure supported. So we're giving a little bit of pressure support. It's like a turbo boost at the beginning of the breath. If the patient wants to pull a volume of 800, like they're coughing, they'll get 800. If they want 1200, they'll get 1200. If they only want 300, they'll get 300. By providing that pressure support, we allow more synchrony with the ventilator because it allows the patient to take whatever breath size they want. So this can encourage better synchrony. And again, in an SIMV mode, there's pressure or volume. And volume control, SIMV, what I want to show you here is that the volumes are pretty much the same during mandatory breaths. However, we see during some spontaneous breaths, the pressure support is given, and then the volume, you can see subtle differences here. During that pressure supported breath, they can kind of take whatever size breath they want. So great for somebody who is not fully sedated. Here we see this is an SIMV pressure. You see the nice square waveform on the pressure waveform. And these people are given pressure, and then whatever volume they get is totally dependent on their own mechanics. And so this, while it looks irregular, is a lot more comfortable for the patient because they can take 500, they can take 400, you know, it's variable. A key thing with that though, is if they are ill or a traumatic brain injury or something like that, where you want to watch their end-tidal CO2, in a mode like this, you don't have as much control over their minute volume or their end-tidal CO2. So you just have to be careful. You're muted, Dr. Kaniecki.
Hey, Tanner, can you go back a slide?
Yep.
Can you, I think it's good for people when somebody's in a pressure mode, the question is, all right, well, what stops the pressure? Can you briefly speak to that, to like what stops the breath for the patients, like flow termination, or is it the percentage of flow, or is it the time that the patient's on a pressure?
There's a couple different ways to terminate the breath. And in a volume control mode, the breath is terminated when you get to the volume selected. In a pressure controlled mode, it's going to deliver that pressure for the length of the I time. And whatever volume you get is dependent. But in a spontaneous breath, a pressure supported breath, there's something called, as you said, flow termination, or in the Hamilton, it's expiratory trigger sensitivity. And when there's a decrease in flow of usually about 30%, it will terminate the breath. But in a pressure controlled mode, it will deliver that pressure for the length of the I time. And during spontaneous, and that's for mandatory breaths. And then spontaneous breaths, it's usually terminated based on a decrease of flow, either that or you hit the I time. Does that kind of answer that?
Yeah, I was just looking for an explanation. It does. I know there's going to be a lot of audience, different ventilators watching this presentation. And, you know, at the end of the day, I guess I want to highlight, and it's unfortunate that the transport ventilator really doesn't have AC, volume control or pressure control, but whatever mode you're using or vent, you kind of just have to understand it, that mode, you know. I kind of agree with you. Like, you don't need to be a master of all. Pick one, start there, be a master of it. And then if you want to build from that, go ahead.
I would agree. And there, with the different ventilators, everybody's going to call something a little different. If you really want to go down a rabbit hole, there's the Chatburn taxonomy of ventilator modes, and there's hundreds of different ventilator modes, and each company is going to have something proprietary to separate them from somebody else. And as you said, and you know, the Hamilton is, there's really no way to guarantee a volume in there because it's pressure driven at its baseline. However, I think I agree with you, it is important to understand the basic modes and then the idiosyncrasy of your ventilator and how to manipulate them to achieve what you want. And, you know, really looking into sometimes either the user manual, the online website, or videos that go over kind of the differences in their modes and how to apply them.
Yeah, that's a good point too, because a very similar mode might be called something totally different by another manufacturer.
And perfect example here. So this is PSIMV plus on the Hamilton, which is my personal mode of choice. But it's an SIMV pressure with pressure support. I mean, there's a whole bunch of different ways you can call this. Hamilton just calls it PSIMV plus. And what this is I like it because it shows you here the CO2 elimination, oxygenation, and synchronization, all these different variables. And they have this on their website for all the different vents, but it shows you how a patient trigger, like right here, will initiate a spontaneous breath because it's during this spontaneous period, where if they didn't take a breath by then, during this mandatory period, it would deliver a breath. So in PSIMV plus on the Hamilton, it's a pressure mode of ventilation, so the tidal volume is variable. It's SIMV in that every breath is fully supported. There's an underlying rate, there's a basal rate, 12, 14, whatever set by the clinician, and then the patient can breathe over that. And if they're breathing over that during this spontaneous period, it actually resets the breath timer so that you don't necessarily get that dyssynchrony like in an assist control mode, where a spontaneous breath too close to a mandatory breath will just lead to breath stacking. So what's great about this mode is that you don't get the breath stacking because you get the reset of the timer for a spontaneous breath. And the spontaneous breaths are pressure supported. So again, if it's like a cough or something like that, you'll get whatever volume you wish. These little pictograms are on Hamilton's website and do a great job of explaining their different modes. And if you ever wonder, you know, what is actually controlling CO2 elimination? Well, the pressure you have set and your respiratory rate. Oxygenation is PEEP and FiO2, and then your IDE ratio. So these are some great little pictographs on the Hamilton website. So how do you select a strategy? This aim before you act thing, you know, assess your patient needs, identify the technical capability. Most modern transport ventilators can handle all this, and then match the technology to the patient needs. At the end of the day, you're really worried about safety, comfort, liberation. So reducing lung injury or preventing lung injury. patient comfort in supporting spontaneous respiration and then eventually liberating them from the vent. So as we talked about for those indications for mechanical ventilation, we'll talk about those really quick. Inadequate oxygenation, commonly from atelectasis, lung infection, or pediatric ARDS, results in VQ mismatch and interpulmonary shunting. Problems related to hypoxemia, not hypercapnia. It's an oxygenation problem, not a ventilation problem. What do? Lung protective ventilation, the classic lung protective ventilation. What does that mean? So if we actually look at the PARDS data, the pediatric ARDS data, it's mixed, as with all critical care studies, right? But there's actually signals toward a mortality benefit following low tidal volume strategies. However, ultra low tidal volumes, less than 4 per kilo, could increase mortality and should be used sparingly. And interestingly, as it's mixed, Kamani showed more vent-free days with a higher volume of 10 per kilo, but in less severe disease, and there wasn't a mortality benefit. So, people with less severe disease, that increased volume probably won't hurt them. And it's interesting to think that maybe those higher volumes, got rid of that dead space and really just increased spontaneous breathing and really fully supported the child. So we should be using a lower tidal volume, 6 to 8 per kg, mLs per kg. But remember, titrate to chest rise and make sure that you're actually ventilating the child. The data is mixed, and we probably won't get any high quality trials because there's some limitation and ethical concerns with designing a trial of large tidal volume when we know that low tidal volume has a mortality benefit in both adults and kids. So we're not going to design another trial with a super high tidal volume because we know that's bad. And it's interesting, Kamani's results go along with the Dieterman trial regarding mortality, where, they didn't really see a mortality difference with, higher 10 versus 6. However, he had fewer or more event-free days, which is interesting to consider. I think it just, remember those dead space considerations, maybe they had less dead space. So here's some initial settings for pressure-controlled mechanical ventilation in children. These charts, there's no way I can make them myself, and there's also something to be said about how coming. I want people who are watching this to know where I got this information. It's not coming from me. It's coming from UpToDate. It's coming from experts in the field, and so I have a couple of these initial settings for children. And so it talks about infants, toddlers, and adolescents, and where to set your PIPs, your PEEPs, respiratory rates, I times. A lot of this information is available on your apps, Critical, PDStat, or your reference card. So I'm not going to go through all of these initially, but just know they're on here. We can make these slides available, but I got them from UpToDate, how to initiate mechanical ventilation in children. A big thing in hypoxia, the inadequate oxygenation, is the importance of PEEP to manage that hypoxia. Remember, if you have low tidal volumes, that can cause hypercapnia. And so either increase your respiratory rate or increase the tidal volume. But remember the importance of PEEP in somebody. But lung protective ventilation, low tidal volume, high PEEP, watch your FiO2. Excuse me. For inadequate ventilation, can be broken down into 2 main categories. Ineffective respiration, you treat them as above. If it's neuromuscular disease, seizure, coma, from altered mental status, whatever, just manage them with a lung protective strategy. Low volume, high PEEP. The other one that is more difficult is obstructive disease, asthma, bronchiolitis. So our goals in obstructive disease are to offload the work of breathing. They're usually working pretty hard, and relieve respiratory muscle fatigue. Again, they're working really, really hard to breathe. Low respiratory rate to maximize E time. So bring that respiratory rate way, way down and maximize the time you have to exhale and get rid of that CO2. Allow for permissive hypercapnia. So, an end tidal of 80 is scary, but it's usually well tolerated, especially in the bad asthmatics. Adequate but not excessive oxygenation. Asthma is not a disease of hypoxia. And I always think if I have an asthmatic kid who's saturating, always be mindful, like a mucus plug, maybe your oxygen bottle's dry, look for some other problem, because usually asthma is not a hypoxia problem. And we want to minimize lung injury. So initial vent settings in children with status asthmaticus. I think is really important. 8 to 10 per kilo, 8 to 12 per minute, which is really scary. So kind of right in the middle, I'll call it 10. we always worry with a kid, oh my goodness, they need to breathe 30, 40 times a minute. In asthma, that's not the case. They really need to be breathing like 8 to 12 times a minute. I time of a second. So if your respiratory rate is 12, that's a 5-second breath cycle. I time is 1, you get 4 seconds for exhalation. That's a 1-to-4 ratio. It's really important. They need that long E time. So here you see IAE 1 to 3, 1 to 5. Super, super important that we drop that respiratory rate in kids. Adjustments for kids in asthma, if there's auto PEEP or dynamic hyperinflation, lower the respiratory rate. Give them that time to exhale. You can pull them off the vent, press down on the chest, try to get rid of some of that extra air. Decrease the I time. Just know it won't be as effective as decreasing your respiratory rate. Got to have those continuous nebs. Use your adjunct medicines. Ketamine's got some bronchodilatory effects, so if you need some sedation plus some bronchodilation, ketamine's a great drug. Use your magnesium. Remember, magnesium it doesn't decrease mortality. It should be used as an adjunct, maybe not first line, but it's more of like a, continue it along the way, but it shouldn't be the first thing that you do. A great trial was done on magnesium, also available on UpToDate. Epinephrine for severe disease, and then your steroids. So remember all that, and continuous steps, I think, is the best thing. Switch to pressure control. Remember, volume's variable with pressure, but you're limiting your pressure at that point. And with a low respiratory rate, you can kind of maximize it. Call for help. And this is somebody with, if you have somebody with severe or significant disease, call for help, use your resources. A couple of very special cases. We're going to talk about elevated ICP, DKA, and aspirin overdose. So elevated ICP, target PCO2 is 35 to 40, low normal. So gone are the days that we're hyperventilating. We are not hyperventilating. It increases mortality. We're not doing that anymore. Unless they're literally being pushed to the operating room. We're not hyperventilating. So we're going to shoot for low normal, 35 to 40. Minimize hyperoxia, so bring that FiO2 down, 92 and above. Provide adequate analgesia and sedation to reduce intracranial pressure. Ensure the head's midline, sit them upright, loosen the cervical collar, use a commercial tube holder, not the twill ties that I think some of us use out there. So, really important. But the big thing from the ventilator perspective is to keep them upright, loosen the collar, and keep their PCO2 35 to 40. Low normal. We're not hyperventilating anymore. In diabetic ketoacidosis, try and match their pre-intubation end-tidal CO2, PCO2, or minute volume, whichever of those numbers you have. You have to ensure an adequate respiratory rate. Caution should be exercised in certain modes. We didn't really talk about ASV, but ASV is an intelligent mode of ventilation. And it's one where you set the minute volume and the vent adjusts pressure and respiratory rate to try to match kind of lung mechanics. It's a very neat mode. It has its uses. DKA is not one of them. And underventilating these kids will lead to cardiac arrest. So these kids really need high minute volume, high respiratory rate. We got to blow off that acid. And just remember that sodium bicarb has little empiric use without explicit instruction. And the instructions that I've read, unless their pH is 6.9, it's under 7.0, we're not giving bicarb anyway. But one thing to remember is if we give bicarb, we're just converting to another acid, to carbonic acid. So we need to get rid of that acid still. If you're giving bicarb, you have to jack up the respiratory rate. Otherwise, you don't change the pH. So DKA kids, gotta really, really ventilate them. Pretty similar in ASA poisoning. The more acidotic they are, you have increased permeability of salicylates across the blood-brain barrier, which can worsen toxicity. So really increase the minute volume, increase the respiratory rate to match that pre-intubation PCO2, and you want to try to fix that acidosis in the acute sense to minimize the toxicity, and if you can, avoid intubation.
Hey, Tanner, I just want to bring up a good point when ventilating the acidotic patient, because a lot of times we come on, they're in the ER or whatnot, and there's no end-tidal CO2. These patients' CO2 in their body is going to be low, 20s, whatever, teens, depends on how acidotic they are. Normal like end-tidal in the 40s, and a patient who's acidotic means you're not keeping up with their ventilation. So
Absolutely
don't,
agree.
that's like the one time where if you have an acidotic patient, like I'm cool with an end tidal of 15, 18, whatever. And ideally, the best way is to have an end tidal and then send an ABG so you kind of get a feel for kind of what the gap is. But these patients, the end tidal should not be 40 because you're not keeping up with their ventilation. That's it.
Yeah, completely agree. If their end tidal is 20 before you intubate them, it needs to be 20 after they're on the ventilator. I mean, because you really, again, it's kind of counterintuitive, but you really need to blow off that acid. And again, in the transport environment, we may not be able to send the gas, and so just try to match that end tidal. Just provide adequate oxygenation. We can back off in the ICU, but we really, under ventilating these kids will lead to poor outcomes. So maintain adequate ventilation. If the kid acutely decompensates, remember your ABCs, airway, breathing, circulation. Check for life threats. Use your DOPE mnemonics, so displacement of the endotracheal tube. That includes right main stem if it's too deep. Obstruction of the airway or tube. Think about kinking, mucus plug. P for pneumothorax, not likely. We shouldn't be, needling kids' chests right away, but think of pneumothorax, especially with high inspiratory pressures out of nowhere. And E for equipment failure. So this, you really should be working through all this other stuff before we pull them off the vent and start bagging them. But remember your DOPE mnemonic. Confirm you have a working oxygen source, especially in transport. If you got a dry bottle, confirm you got good oxygen. Get a chest X-ray. You can rule out pneumothorax pretty quickly. You can check for placement of the endotracheal tube, and call for help. Call for help early and often.
Hey, Tanner, I had an internet issue and I jumped off and I'm back on, but did you also discuss how stomach, OG, and like how that can be a big deal?
You know what, I didn't, and that brings up a great point. These kids can have higher PIPs, higher in low volumes on the vent because they get these nice big bellies. So gastric decompression is huge, and so that's a great point, Dr. Kaniecki. Thank you for bringing that up. Drop an OG in these kids early and decompress that stomach, because that increased abdominal pressure can absolutely kind of displace things in the chest and increase your PIPs. So yeah, great point. Got to decompress these kids' abdomens early.
Yeah, same concepts here for a pregnant person or somebody with an intra-abdominal infection or like ascites, these same things that you're limiting ventilation with that. So whatever you can do to improve it. And then in a kid, decompress the stomach.
Yeah, absolutely. Great point. This is a quick algorithm about respiratory distress or hemodynamic instability. The only thing I don't like about this is they say disconnect the patient from the ventilator and manually, use 100% oxygen. We don't need to do that. Run through your DOPE mnemonic first, but we can just think about other things, which is checking for an air leak, passing a suction catheter, looking for a mucus plug, suction them out. If you have to manually ventilate them, that's fine. But look for reversible causes. Are they biting on the endotracheal tube? Is it kinked? Is it twisted? Is it obstructed? Do they need sedation? Are they having respiratory distress from low volumes? Remember, if you're in a pressure controlled mode and the endotracheal tube gets kinked, the vent's still delivering that pressure, but the patient's not getting any volume. So super important to look at your ventilator as well and understand what mode you're in, and what to watch out for. But I think this algorithm is good because it just, again, looks for, you have your DOPE mnemonic. It tells you to suction them, check for an air leak, etc. So there's a lot that you can do if they actually start to deteriorate. This is a good kind of picture about if the PIP is elevated. And as you were talking about earlier, the gap between PIP and plateau, possible causes, mucus plug, obstruction or bronchospasm, less likely maybe in the acute setting, like they're not getting a pleural effusion out of nowhere, but that's something if they have them, on your chest x-ray, then that may be something you need to drain later on. If there's a drop in the PIP, is it an esophageal intubation? Has it migrated above the cords, especially with those kids? Nobody should really be using uncuffed endotracheal tubes anymore, but God forbid they have an uncuffed endotracheal tube. Got to be super mindful of where that tube is. Or is there a leak? Did the balloon rupture? No, they say PE can happen from drop and PIP. I've never seen that. Usually they have underlying long injury to begin with. So in review, utilize proper settings depending on the presenting pathology. Use your help, use your reference cards. In asthma, they need that low respiratory rate, super important. When in doubt, ask for help. Call the PICU, call the intensivist, utilize your resources, your medical director, your medical control. These, it's better to kind of check the ego at the door and say, hey, I want to ventilate this kid properly. I want to, do the right thing for this kid. Ask for help early and often. Use your references, Pedistat, critical, Broslo tapes, reference apps, whatever, as long as it's validated. Remember your dope mnemonic for respiratory distress, displacement of the endotracheal tube, obstruction or kinking, pneumothorax, equipment failure, and please provide sufficient analgesia and sedation. Especially people love to intubate with etomidate and rock. They're sedated for 3 minutes and paralyzed for 40. So, provide that sedation and analgesia early and often. Just a couple references. And that's what I got.
Yeah, good job. I think, like I said earlier, I think, if people who are watching this are like nurses or new NPs, when you're doing flight, I think the biggest learning curve is the ventilator, right? And I just remember myself earlier in my career, alarm, silence, like that's not the move. Whatever, the way to learn this is time. They're not going to watch this one lecture and kind of be vent masters. And I have found hooking up the lung, watching what's going on, reading, but especially like playing with the ventilators, ultimately what people have to do, and then squeeze the lung, put more compliance on it, see what happens. And because that's really, what we do. Yeah. Yeah, great. High five. You intubate somebody, but if you're not smart enough to know to increase the rate and ventilate that patient, they're going to rest in 15 minutes anyway, right? So I don't know. I just encourage people who watch this to really learn the vent, understand it, and kind of go from there. I would say, I mean, all your concepts are important, but especially patients on volume control. Like you got to understand the pressures you're creating with that volume. Patients on pressure control, you got to understand what volumes you're creating with that pressure. And if you're not creating that volume, yeah, maybe the answer is more of a driving pressure, or maybe it's slowing the ramp time, slowing the I time. There's all these little maneuvers that you can do with the ventilator to ventilate them. You have any comments on actually like, because you're good at the vent, you're way better than most people, right? You're an educator. Any comments on how people who are just say novices can like maybe learn?
I agree with you. I think it's learning the knobology, the buttons, the different modes, and however you learn the modes, whether that's YouTube videos. I mean, there's people explain it in a lot of different ways, and sometimes with the way I explain it won't make sense, but the way Scott Weingart or Rishi Kumar, somebody else explains it will make sense. So find a way that makes sense to you. And regarding our specific topic, ventilating kids, I think a lot of transport teams that use or the transport kids have respiratory therapists. So use your respiratory therapist, play with the vent, learn the vent, and try to understand some of those foundational concepts, as you said, volume versus pressure and what to watch out for. And then understand your different pathology. How are you going to intubate somebody with pneumonia versus how you're, or not intubate, but how you're going to ventilate somebody with pneumonia versus how you're going to ventilate somebody with asthma. And so you don't have to be a master of the vent and all the different settings, but you should have a foundational knowledge of those basic modes and how to apply them, when to apply them. And I really think for transport, especially, troubleshooting is, if not the most important thing, one of the most important things, because a lot of adults will do fine on volume 350, 5 a P, 100% F2, whatever your standard settings you find them on. But understanding how to troubleshoot and get out of trouble is just as important. So I think that, learning, using your YouTube videos, learning from your intensivist, learning from your respiratory therapist, if you've got one on the team, is super important. And then just the hands-on application of the vent. And if you have a test lung, increase the pressure. What happens to your volume? Increase
Yeah.
the volume. What happens to your pressure? You know, just and playing.
Yeah, and I run the ventilator all day long in the ICU with adults, but you know, I have an idea when I fly a kid, but I mean, honestly, like there's some, you know, there's some fear of the unknown, but I couldn't imagine doing it, not knowing these basic concepts. But so here's a question for you for those who maybe are good at adults. So young child sees whatever is kind of normal pathology. Intubated when you get there, you have no baseline parameters. How do you choose your initial settings? Do you just like look up a pediastat? This is a normal rate, a normal tidal volume for this kid. Let's start there and kind of see what happens with the volumes or pressures or whatever you're doing. Is that kind of your approach?
So there's two ways of doing it, and I think one of them is going into Critical or Pedistat or whatever app your choice is, and understanding what the baseline is. And then if you depending on the ventilator you have, so I'll have an understanding that their tidal volume should be about 120, about 130, whatever. Rate should be about 20. I'll then go in on the Hamilton. If you enter the patient's weight, it'll give you settings.
Yeah.
Those are usually pretty accurate. Then I start there and then adjust to my end-tidal CO2. I adjust to chest rise, making sure I'm actually oxygenating the kid, actually ventilating the kid, and kind of go from there. And if the patient looks air hungry, give them a little more volume, give them a little more pressure. If they're in significant respiratory distress, give them some more rate. I mean, they're trying to breathe. Let them do it and maybe use a mode that is supportive of that breathing, like an SIMV. So I'll usually use my app to understand where the baseline should be, start there, and just adjust to those variables.
Yeah, that's how I would approach it. Again, knowing adults, which I'm assuming a lot of people who watch this will. That's what I would do as well. I look at where are the normals, and then I personally like volume control. That's my comfort, right? So I would choose the rate for a kid, the volume for that kid. I would put them on it, and I would, using volume control, I would watch my pips and my plateaus. And if they were normalish, then I'd like you, I would watch my end tidal or the CO2. If it's going up, I need to either adjust my rate or my volume. And again, this is not knowing kids, but if I have to adjust my rate, I would make sure I looked at the exhalation waveform just to make sure they're blowing off and I'm not breath stacking. And I hope it's kind of as easy as that. And most trips really are that, and it's not high or advanced, but for sure, I would be on the phone if those like initial maneuvers weren't working well. But I think kind of what I just talked to should be fundamental if anybody's going to move a young one on a volume mode. And I really think if you don't know that, then man, maybe you shouldn't be flying that kid, because these kids are young, and they have a long life in front of them. And the one thing we can do, if you're not doing it right, I mean, you can either one, just hit a bunch of alarms and now you're not ventilating the kid, or you can give them too much pressure and you're going to potentially blow a lung. So I think this is a fundamental skill, whatever mode. What do you think, Tanner? That's kind of my feeling. And if you're not comfortable with it, you better get an RT, or maybe shouldn't be flying the kid, because that's what we're asked to do, is just don't mess this up. We're not asked to high level stuff, right? With these little ones, but we are asked to know the basics and don't mess that kid up.
I would agree, and I think what a couple of things you said in the volume mode. Watch that VTE. Make sure that you watch your pips and plateaus with that VTE. Make sure there's air coming back. That
Yeah.
because you're conscious about dead space. I think that one of the things that transport is understanding that we can move a lot of people, but there are certain people that I'm not moving a kid in an isolate because I'm not the person to move the kid in an isolate.
Yeah.
Now that I'm a father to two children, like I want the best thing for my kids and I want the best thing for all kids. And if I'm I'm not above saying I'm not the right person to do this. It's not for me. This is not the trip for me. However, I am comfortable enough in the basics to take most kids, and I'll call for help, and I'll call to pick you and say, this, I'm at the bedside, this is what I got, and I'll put the kid on my ventilator first. and
Yeah.
say, what's wrong? I mean, if something's going to go wrong, it's going to go wrong usually pretty quick. And so I'll have the PICU on the phone and say, what do I need to do differently, or what do you recommend? But I think if there is a hesitation, or you're super uncomfortable moving a real sick kid or a real little kid, find the resources to move that kid safely and efficiently. Maybe it's another team, maybe it's adding an RT, maybe it's adding a PICU person, but it's too important to not to gamble with.
Yeah. I think I kind of feel like we're on the same page. And all programs are going to be different, but most flight teams, you're going to get called to fly a 2-year-old that's whatever happened, right? And you can't ask for another team on those patients. Like, you need to know the fundamentals, and you need to know
Yeah,
how to ventilate normal pathology. But if you find yourself getting to like these high, you also need to know where, hey, I just don't know this and I need more help. And that's fine, But so this was a good talk. I appreciate it. Unless you have not anything else, I'll stop.
thanks for having me.
Sure.